Having a sense of self, a sense of purpose, a sense of meaning is really protective for psychological health and well-being. Can't just be one, right? More diversified sources of purpose and meaning give you a greater diversified pool of identities to lean into if one isn't going particularly well or one is threatened, say through occupational illness or injury. And so, what I think you're starting to see through generational changes is this recognition that there's more to life than work. Work can certainly be part of your identity and give you a sense of purpose and meaning fulfillment, maybe even a substantial portion of that purpose and meaning fulfillment. But there's limits, there's boundaries. And maybe some of the younger people that are coming in have different values around how they balance these things that some of us old timers maybe didn't have as much.
Do you think there'd be a role for like early career kind of screening for just people that might have like higher predispositions for these like mental health issues that we've discussed? And then at least like set a baseline so that we can see what's changed like throughout your career. Cause I think a lot of the time people see psychologists once they realize there's a problem, but they don't get assessed, at the beginning of the career before they did that traumatic call. Do you think there'd be a role
Short
for that?
answer, probably. Long answer is a little bit more complicated. A lot of people ask me about this and they point to police and they say police have psychological assessments as part of the entry to practice requirements. And oftentimes they have semi-compulsory or mandatory check-ins with mental health professionals. Bear in mind that on the screening part, the focus is different. We're taking an ordinary citizen, we're putting them through recruit police training, we're giving them a weapon, and we're putting them in a position of enormous power in society. The psychological testing is intended to ensure that this person is stable, right, and able to execute that office with that power and responsibility in a way that's socially responsible. So our pre-employment screening, when people ask me about it, the thing that worries me is a lot of people say it's the young kids and they're going off with PTSD and we just need to find the ones that are resilient and they're not going to be affected by this. And I would respond in two ways. One, it's not the young guys. I have data on this from over 1,000 paramedics now. There's a curve that shows risk of PTSD correlating with years of experience. It goes up. And conceptually, that makes a lot of sense because you have accumulated trauma exposure over time. So let's not place blame on anyone, least of all young people that are choosing voluntarily to enter a profession. But I agree with you that when we're bringing people into the profession, having mental health assessments, having a relationship with a mental health professional is super important. And there may be cases where people have a predisposition or have a pre-existing mental health condition that could be exacerbated by some of the stressors that we encounter. And maybe we want to coach them, not exclude them, but help them develop systems and processes that let them be more resilient. Is that fair?
Yeah, definitely. I think like you said, as a screening tool, I don't think that would be appropriate or ethical. We don't want to say you can't be a paramedic because of this, but maybe just to set a baseline so that we can, find those that might need a little bit extra help early on, and then be able to prove that there's been a change throughout their career. I guess that's especially important for like WSIB coverage and things like that, right? Like getting on the legal side, if they'll try to deny you if you've already got something going on.
The other thing I would say is because typically people want to screen for resiliency. Okay. As we talked about, it's person and environment. There's personal factors that let you be more resilient. There's environmental factors that let you be more resilient. It's not a stable thing. One, it's hard to define, but two, it changes. It changes day to day. It can change really significantly. So what if you screen somebody and they have what you might consider to be a low resilient disposition? Maybe they got some stuff going on in their life, and maybe in a couple of months, they're doing really well, or maybe they're really resilient in that moment and then something really big comes up later on. Like COVID, how many of us were feeling super resilient when we were entering work as paramedics during especially the early months of the COVID-19 pandemic? I know I wasn't. I was struggling with a lot of stuff that was happening at home at the same time that I was juggling a PhD, at the same time that I was tasked with putting together a special operations team for our paramedic service. I was in a rough spot. I was getting it done, but I was in a rough spot. I would hate to say that we would disqualify somebody from entering this profession on something that changes so much, especially if we're recruiting, say, Gen Z, for example, who are going to grow and mature and change, not least of which in their neurochemistry, right? So like it's something that evolves over the course of a lifetime and certainly over the course of career as well. So it's really tough to say, when should we screen them? What's the value of how much resilience they should have? And then how do we filter them out.
So I guess just teaching those resilience skills to the population as a whole might be a solution to get some more stability in the system.
I think it's part of it. Like we talked about, person in environment. Plug the holes that we can, control the things that we can't control, stack the odds in our favor, and then just be honest and upfront and recognizing that some of the risk is just attributable. It's probably not going away.
I think you said such an appreciable point about your own kind of struggles during a certain period, because this is from like behind the curtains where only paramedics and other healthcare professionals would understand. It's that you could have had a fight with your spouse. You could be going through a divorce. You may have not have slept well. You could be a tough time with your kids. And then you come to work and you try to forget all that if you can. Then you deal with serious calls or not, and everything's just compounding. And you can see why all these depressive episodes can ascend in this population, because that's more the human side of things that maybe people don't understand paramedics go through. And maybe even as coworkers, we don't appreciate that other people are going through, and then we just quote unquote facetiously say, they're just burnt out. And we just shrug our shoulders, which is sad, right?
I mean, I think you hit the nail on the head perfectly. We're people. All the same things that ordinary people, using a loaded word, deal with, we deal with too. And then to your point, okay, now let's go deal with some occupational trauma and maybe violence at the same time.
And I think about the stereotype and just perpetuating that stigmatization that, the young people don't have resilience. And if everyone keeps saying that and they internalize that now, like, how's this a self-fulfilling prophecy? It's like, well, now I feel bad. I can't have this resilience, and now I may not report it and go off when I need to, and I just keep suffering.
They probably have different values, right? I think in some ways they're really wise. So come back to some of the earlier work I did on role identity. So you'll see dispositional changes in this with experience. A really short version of this. It's important to have identities, things that you identify with that make up part of your sense of self. Having a sense of self, a sense of purpose, a sense of meaning is really protective for psychological health and well-being. Can't just be one, right? More diversified sources of purpose and meaning give you a greater diversified pool of identities to lean into if one isn't going particularly well or one is threatened, say through occupational illness or injury. And so what I think you're starting to see through generational changes is this recognition that there's more to life than work. Work can certainly be part of your identity and give you a sense of purpose and meaning fulfillment, maybe even a substantial portion of that purpose and meaning fulfillment. But there's limits, there's boundaries. And maybe some of the younger people that are coming in have different values around how they balance these things that some of us old timers maybe didn't have as much.
I think that's such an undervalued point, that obviously each generation has different experiences, different values, and that overall shapes how we view and perceive the world. And that's not up to us to necessarily change their views, but how can we support you with system level changes and overall try to plug as many holes as we can to make sure you have long and prosperous careers?
I think we meet in the middle. Some of this, if you read some of the research on Gen Z in particular, this idea of prolonged adolescence. So anecdotally, we had a recruit class come in, and a large portion of them didn't have their Class F driver's licenses, for example, which kind of tracks to some other research that's looking at Gen Z that shows that milestones of traditional adulthood are a little bit delayed. So we probably need to meet on the middle on some of these things. Get your driver's license, get your Class F, right, to go be a paramedic. But certainly we can learn things from the younger generation because they're going to carry the profession for us. It's not going to be me. Right?
That's the thing. They're the future, and we have to make sure they get to the future as healthy as possible. And if we go back to some of the prevalence of violence towards paramedics, what's the most common form of violence paramedics experience every day?
On its own, verbal abuse, generally. The problem is, and we see this in our reporting data, there's not normally just one type. It's somebody who's verbally abusive, that's threatening, that's sexually harassing, that escalates and is actually physically assaultive. So the paramedics, when they fill out the reports, can tick multiple free text choices for different types of violence. If you dichotomize those, you just say, okay, what percentage of reports document some form of physical or sexual assault, either on its own or in combination with other forms of violence? Within our service, it's about 40%. Within the data that we have from other services using the same reporting mechanism in the province, which is about 3,000 reports that we've looked at, that percentage of documenting some form of physical or sexual assault is closer to 60. I think some of that is some reporting bias. Again, the above about volitionality and severity, those less serious incidents don't get documented as regularly as the more serious ones do. But on its own, verbal abuse, and then in a pretty substantial portion, people are talking about some form of use or threat of use of force.
How does that affect paramedics' mental health every day if they come to work knowing I could be verbally abused at minimum, all the way to range into the most severe, like sexual assault or even violence, right?
We have data on this now. This probably won't surprise anybody here. It increases the risk of post-traumatic stress injuries. We're able to put some numbers to this now, for example. So see above the study we were doing on paramedic mental health, people could participate anonymously, they could participate confidentially. Confidentially, they're identifiable to us, and that means we're able to link their mental health screening scores to their violence report data. On the other hand, start to suss out potential dose-response relationships. And we're seeing a trend there, and it makes intuitive sense between increased violence exposure and an increased risk of, say, things like PTSD symptoms or depression. The risk is really pronounced for burnout, which is a form of emotional and physical exhaustion. It's often attributable to work. And so we see that risk being especially significant, to your point about going up to work every day and people are just being really verbally abusive. The other dynamic to this, apart from if somebody punches you, you could get hurt, there's also this verbal non-physical violence that in many cases, we did another study on this, has components of it that involve racist or sexist or homophobic language. And when we crunch the numbers on that, we find that paramedics who report those types of violence are more likely to be emotionally distressed at the time of reporting. So there's physical injury, there's emotional distress, and then there's, DSM-5 level potential psychiatric diagnoses that we're starting to see firm up in a relationship between exposure to violence and these mental health impacts. It has a huge impact potentially.
I'm just thinking the ripple effects, because that is very severe consequences to experience that, especially like the homophobic slurs and the sexual assaults and everything, like just devastating. And I just think about too, like how does that change the perception of paramedics doing these calls potentially in the future? Because correct me if I'm wrong, the vast majority of violence calls, disproportionately, it's from people intoxicated or with mental health disorders, leading to these increased risk of violence and everything.
So that's a needle we have to thread really carefully. Yes, in the reports that we see, mental health, substance use, alcohol intoxication, those types of things are implicated in something like 85% of the reports. You're listed as contributing circumstances in up to 85% of the reports. When we look at the primary presenting problem on the ambulance call report, the ACR, so this is after a paramedic's done an exam, taken a history, measured vital signs, and then they're coming up with an impression of what the main reason is this person's called 911. Conservatively, where the primary presenting problem is related to mental health or substance use, about 7% of our overall call volume or caseload. It's 60% of our assaults. It's really high. And so the important thing here to realize is that it's not necessarily that people with mental illness are inherently violent. I think the opposite is actually true, and the data bear that out. Is that we see this small slice that under the right conditions can be violent, and the nature of our work exposes us to it and also makes it much more difficult to mitigate, to control against, just because we're entering into people's environments, they're uncontrolled, they're in the public, they have access to improvised weapons or real weapons, for example. And you're not you when you're hungry. So we need to work out ways to recognize these contributing circumstances and then get ahead of them to mitigate the risk.
So that's such a good point that we just kind of get this very brief moment in time, and maybe our perception to it gets altered, especially if something negative happens. So we may be heightened when we see intoxicated patients later on, even though they may be safe in the grand scheme of things. And I'm just thinking about the location of where these assaults typically take place. Is it at the residence, or is it typically in the ambulance or in the hospital? Which one?
All over the map, a lot of the more serious physical incidents are happening in public locations and long-term care. Interestingly, that came out when we did regression modeling on this as a high-risk pickup location. That makes sense, people with cognitive impairments, for example. But to get to your point, most of the violence is happening at the scene. A lot of it is also either initiating or consisting in transit to hospital, and in up to, I think, 40%, of the cases that we have with the data we have, it's either starting or continuing after arrival at the receiving emergency department, which really surprised me because there's environmental affordances that I would have thought would have reduced that risk even further compared to the kinds of environments that we're operating in when we're at the scene of the emergency. So it's a variety of different locations. It tends to stratify a little bit by type of violence.
So, from a system perspective, then, how do we mitigate those risks depending on the location?
And the primary problem, I would say, right? So if we accept for a moment that people with mental illness generally are not violent, more likely to be the victims of violence, but the nature of our work exposes us to situations where mental health crises are at a crisis level, and it can be difficult to de-escalate from or mitigate. So then we need to try and identify these calls and then get ahead of them. So if we identify high risk problem type calls, say something involving mental health or substance use or addictions in a high risk type location, a public setting, a bar, for example, then we need to deploy resources to try and mitigate the risk of violence, not just for our safety, but also for the patient's safety. Because if we are physically fighting with a patient, if they're being restrained or sedated, we see that those are inherently high risk encounters, not least of all for the patient, who could potentially die. We've seen cases of that in the United States with severe violent psychosis sedation. So there's a researcher in Ontario, Dr. Polly Ford Jones, who is a paramedic at Halton Region for a long time. She's faculty at Humber College. She did a PhD at York University. She looked at paramedic responses to people experiencing mental health crises, and she works with paramedic services in the province to develop alternate transport, treatment referral, response pathways for people accessing EMS with mental health concerns. And they approach it from a trauma-informed interdisciplinary perspective that recognizes the needs of the person. And so that helps to address this misalignment, right, between what the patient is accessing the service for and what we're able to provide. So these are lining up closer. That's good for patients. It's also good for safety.
I'm just thinking, I don't know if people's perspectives, they want justice side of things or just reporting or just culpability, but let's say you get called to the nursing home because you said a high risk area is the nursing home. What if the elderly patient fell, hit their head, they now have intracranial hemorrhage, and that's leading to agitation and leading to violence, and they hit paramedics and assault them verbally, physically? Are we looking at the side are they legally exempt from that due to the pathology, or does it not matter?
Well, with the caveat that I'm not a lawyer, so I don't want to get too far out of my skis on interpreting criminal code. But probably we shouldn't throw them in jail. Now, that's not a very satisfying answer, right? This is one of those things where two things can be true. You should not be assaulted at work. It's not part of your job. It's not accepted. To your earlier question, which you opened the interview with around this quote about violence never being acceptable, that can be true. It can also be true that there are contextual factors that might impair a person's ability to form reasoned decisions. And they react or they act in ways that are dangerous to us. They're hazardous to our health and safety, and we need to take steps to ensure that we're safe and also that the patient is safe. And those systems might fail. They might actually assault a paramedic because they have a cognitive impairment like dementia. We did training on that in Peel Region about how to recognize expressions that could lead to violence among people who have cognitive impairments like dementia because they're just not in a right frame of mind. They think different. Their brain chemistry is different. The solution from a justice perspective isn't to toss this person in a prison. And I don't think most paramedics want that. But they probably want some acknowledgement that I'm really sorry this happened to you. It shouldn't have. And we're going to try and make things safer. But there are people, and it's understandable, who when they experience violence, whether it's verbal abuse or physical assault, they just want this person held accountable. And the perception a lot of the time is that people aren't. And in truth, an uncomfortable truth, a lot of cases, they aren't necessarily held to account criminally because they haven't done something that's criminally wrong. It's a tough situation.
Yeah, we can't underappreciate that because I love that quote. Two things can be true. They can have a serious pathology that's exacerbating this behavior, but also we can appreciate that paramedics aren't supposed to come to work irrespective of the nature of the job, and they shouldn't be hit or verbally assaulted, even if they are having to deal with a patient with that pathology. So that is a very tenuous circumstance to navigate. But I think to your point is that we need to make sure the patient safe and the paramedic safe. And again, how do we go back to controlling everything we can to optimize for both parties?
Usually, if the patient is safe, we are too. And likewise, the reverse is true. If we have good physical safety protections, we usually mean that the patient is also going to be safe. So this is win-win.